Afternoon. We have a nice, quiet, comfy room. So anytime you guys want to stop and interrupt, ask questions, feel free to raise your hand. I don't mind being interrupted. Otherwise, I just tend to keep talking. If you guys can't hear me, just let me know. Before I get started, does anybody in here has had a knee replacement? Excellent. So I won't get any help. We do have 2 people. So I might get some heckling. 3 people.
I had 2 hip replacements.
2 hip replacements. Okay. So correct me if you think I'm saying something incorrect. All right. All right. So today we're really going to be talking about knee arthritis and knee replacement surgery and what we're talking about and what it really means. So my name is Agam Shah. I'm one of the orthopedic surgeons at Orthopedics New England. Just a little bit about me. I did my, after medical school, which I did in New Jersey Medical School, I did my... So after medical school in New Jersey, I did my training at Tufts Medical Center in Boston, as well as New England Baptist Hospital right up in Boston, I guess specifically on Mission Hill. I went on to, after that was a 5-year training program. After that, I spent a year at the University of Massachusetts in Worcester doing specific surgery on only shoulders and knees, becoming very familiar with shoulder and knee surgery. So far in my training, I've been involved with over 3,000 different joint replacements, including primarily knees and hips. I currently have an office at Newton Wellesley Hospital in Natick, very close to the Natick Mall, and in September 2013, so just a couple of months, we'll be opening an office in Dedham, very close to Dedham, Hilton, if you know where that is. Anytime you see a medical speaker give talks, we have to disclose any financial relationships. If you haven't figured it out yet, this talk has been sponsored and is being brought to you by Stryker, which is a company that makes orthopedic implants. However, I want to let you know that I do not receive any financial incentives. I don't get any money for being here. I'm actually just here to inform you guys about total knee replacements, what Stryker has to offer, but they don't pay me to do so. All right, so what are we going to be talking about? First, we're going to be talking about what is knee arthritis, why does it hurt, what can we do for it. In the end, the last thing that we do is general joint replacement surgery, and we're going to talk about what that involves and what you're going to expect after that. So before we talk about what is arthritis, we want to get a sense of what are symptoms of arthritis. A lot of people complain of knee pain. I complain of knee pain if I've been standing all day. Does that mean I have arthritis? No. But common symptoms of arthritis. You no longer participate in an activity that you normally could because you have pain. Do you find yourself taking the elevator instead of the stairs just because every time you take the stairs it hurts? Particularly it hurts more going down than going up, but often, sometimes it will hurt more going up the stairs than going down. You change where you park and you wait for a closer parking spot because you don't want to walk that far into the building. You're not alone. Lots of people in this country have arthritis. There are lots of total joint replacements in this country being done. Otherwise, Stryker wouldn't have me here talking about it. They know that this is a market that's occurring. People want to get their knees replaced because they're getting back to their functional activity. They're able to walk across the parking lot. They're able to go up and down stairs. They're able to get back to the activities that they want to do. So let's talk about the activities that are most effective. Stooping and bending is the #1 activity. Picking something up from the floor, whether it's your shoes, whether it's the cat litter, anything. People have trouble doing that. It affects them day to day. Standing. Who doesn't stand every day? Getting out of bed, you stand. Walking, pushing, stairs, carrying something, sitting, reaching and grasping. These are things you do every day. So every day, if you're complaining about these things, it's a problem. That's why you're here. We want to learn more about what's causing the problem and how we can treat it. All right, let's step back and talk about what arthritis is. Arthritis, by definition, means joint inflammation. If you break down the word arthritis, it has Latin roots. Arth is the Latin word for joint. Itis is the Latin word for inflammation. Therefore, by definition, all arthritis means is joint inflammation. The question is, why is the joint becoming inflamed? If you look at the bones in our knee, there's 3 bones. There's the end of the thigh bone, which we call the femur, the top of the shin bone, which we call the tibia, and the kneecap, which we call the patella. The ends of those bones, where they rub up against each other, are covered with cartilage. Cartilage is this white, shiny stuff that allows everything to move smoothly. If you've ever eaten chicken before, the end of that chicken bone, that white shiny stuff that your teeth can't bite into and constantly slip off of, that's what cartilage is. We have that same stuff on the end of our bones. Cartilage is so smooth that it's 1/10 the friction of ice on ice. As humans, we have not been able to duplicate how smooth cartilage is. We've come in close, and but we can't replace the cartilage once you lose it. So what arthritis is when that cartilage starts to wear down for whatever reason, and we'll talk about the different ways that it can wear down. Your joints don't like it. Instead of running nice and smooth, you have this rough surface. That friction builds up. It builds up the inflammation in the knee. That inflammation causes pain. That's what stops you from doing what you want to do. Now, there are different reasons why that why the cartilage will break down. The first is osteoarthritis, or generalized wear and tear, meaning think of the cartilage like a tire. As you run your car many, many miles, first 1,000 miles, no problem. 10,000 miles, most tires can handle that. 25,000 miles, you start seeing rundown. 50,000 miles, most tires are done. We know that the cartilage in the knee can average anywhere between 40 to 120 years. And the most dependent factor that determines how long the cartilage is going to last is your genetics. So if your parents had bad cartilage, there's a good chance that you're going to have bad cartilage. There's nothing that you can do to change that. There are some factors that can change that, including weight loss. The more weight you put on the cartilage, the faster it's going to run down. So the more weight you lose, or the thinner you are, the less likely you are to run it down through generalized wear and tear. But when you have generalized wear and tear, we call that osteoarthritis. Essentially, arthritis for no other reason except generalized wear and tear. Rheumatoid arthritis. Rheumatoid arthritis is a slightly different type of arthritis. That is what happens then is the body doesn't recognize some of its own tissues and thinks it's a foreign body. And the body doesn't like that, and it starts attacking it, and it causes localized inflammation. That localized inflammation releases these chemicals that start destroying the cartilage. You release the chemicals that start destroying the cartilage starts to break down, and you develop rheumatoid arthritis. Rheumatoid arthritis is a little different than osteoarthritis in the fact that it usually occurs at slightly younger ages, and it's very destructive to the bone and the cartilage once it starts. And when people come in with rheumatoid arthritis, their x-rays are usually pretty horrendous looking. The bone is really pretty badly destroyed. Inflammatory arthritis. Inflammatory arthritis is, there's a whole bunch of different types of arthritis that cause cartilage destruction that don't fall under this generalized wear and tear or rheumatoid arthritis. The most common are gout, pseudo-gout, Lyme disease, psoriatic arthritis. All of these are inflammatory processes. Gout and pseudo-gout are caused by crystals that deposit in your knee. If you've ever seen somebody with gout or pseudo-gout in the knee, they can't walk. It's this big, red, hot leg. After a while, if you have enough of these attacks, it just starts destroying the cartilage. Lyme disease, very similar, except that's caused by a bacteria. It goes in, eventually destroys the cartilage. So that's inflammatory arthritis. Generally, some of these times when people have inflammatory arthritis, we just don't know the cause. We know how to treat it, but we don't know the cause. One of the other types of arthritis which I want to talk about is post-traumatic arthritis. If you were younger and had a lot of injuries, whether it was playing sports, skiing, car accidents, fall from ladders, whatever it was, if you have a lot of injuries to your knee at that time, you can scrape the cartilage, not just generalized wear and tear, but actual scrape or shear injuries to the cartilage. Once that cartilage goes, there's no way to reproduce it, we can't regenerate it, and you can generate post-traumatic arthritis. Any questions regarding that? All right, so osteoarthritis. So now we're talking about the generalized wear and tear. Some people can live with generalized wear and tear in their knees and not have pain for years, and all of a sudden, one day they wake up and their knees hurt and they're stiff. The next day they wake up and they realize they can't walk. That's rare, but it can happen, and that just means that the arthritis has been exacerbated in the knee, and it's been set off, and we have to do what we can to try to control it. Arthritis can cause pain, it can cause stiffness. People get up in the morning, often complain of very stiff knees, and they have to take a couple of steps to get it going. What happens is overnight the knees don't move that much, and the fluid that helps lubricate the knees gets set up in certain pockets, but not in the areas that you need it. And so when you start to move, it starts lubricating, but you got to wait those couple of steps to allow that fluid to get around the whole knee. Sometimes the arthritis can cause swelling. The swelling is just a form of inflammation. Sometimes that swelling leaks out the back of the knee and it forms a cyst in the back of the knee, and you have this big bubble in the back of the knee, and we call that cyst a Baker's cyst. So I often have patients come to my office saying, my doctor says I have a Baker's cyst, what can I do about it? What we do about it is we get rid of the cause of the swelling of the knee, the Baker's cyst goes away. Baker's cyst in and of itself is just a sign that something else is going on with the knee. With these problems, simple tasks do become more difficult to perform. Going up and down stairs, vacuuming the house, driving from point A to B, your knees get stiff while driving. Once you're out to where you're going, your knees hurt while walking. These are all complaints people have. One of the most common complaints people come to me about is they can't sleep because their knee hurts so much. All right, so these are things that we kind of already talked about. I just wanted to show you, so this is a normal knee. This is the end of your thigh bone. This is the top of your shin bone. You have this purple cartilage again, which allows everything to move smoothly. A diseased knee, and we can actually see this very clearly whenever we're doing an operation or looking directly at the ends of our bones, that cartilage really is ratty. It's no longer smooth. It's got holes in it, and it's really destroyed. But when people have pain from this, even though you may have a knee that physically looks like this, you may not have that much pain. And one of the things we're not good at as doctors yet is knowing who's going to have pain with a knee that looks like that. There are some people that can function absolutely fine with a knee like this. There are some people who have a knee that looks much, much better than that, but can't function at all. And we're not sure why. So we don't let what the bone looks like or what the x-rays look like tell us what needs to happen. We listen to the patients. It's the patients that determine what they need to have done. If you have an x-ray that shows that the bone looks like this, I don't care. If you're able to do everything you want to do, God bless. God bless you. Come back to see me when you can't do what you want to do. That being said, when you have the pain, it can be constant throbbing, aching, or it can come and go. It hurts more when I do activities. It can occur, like I said before, with just at rest or with motion. And it can be located in several different body parts. It could be the hips, the knees, the back, the ankles, the wrists, the shoulders, the elbows. It could be isolated to one knee just on the inside. It can be anywhere and everywhere. It might only be in one spot. So let's say you have these symptoms and we think that it's arthritis that's causing it and not some other problems that can occur with the knee. There's a bunch of different things that you can try without having an operation. Now, all the things listed here, I want to mention that these have not been scientifically proven as doctrine to help specifically with arthritis. However, it has not been shown to hurt either. So when people ask me, is it okay if I try hypnosis, if I try acupuncture, if I try aromatherapy, water therapy, I tell them exactly that. I can't tell you that it's going to help. I can't tell you that it's going to hurt from a medical standpoint. But if you think it's going to help, go ahead and do it. If it helps, I'm very glad that it helped you. There is certainly no evidence medically substantiating that it's going to help, but there's nothing that's going to cause it more damage. Herbs and other natural remedies, massage therapy, meditation, water therapy, all very similar. I just want to touch very quickly on herbs and other natural remedies. One of my professors during med school told me that a herb or a natural remedy, all it is, it's a drug that just hasn't been proven to work yet. Once it's proven to work, it's no longer a herb or natural remedy, but it's going to be marketed as a drug. Now, let's talk about stuff that has been proven to work. We talked earlier about diet and exercise. So we talked about weight loss. If you're able to lose weight, you take the pressure off the joints. It doesn't see as much pressure. It's not going to get inflamed as much. It doesn't see as much friction. It makes you feel better. Exercise. Exercise works for two reasons. One, it helps you lose weight, but two, it keeps all the muscles around your knees strong. If you keep those muscles around the knees strong, it decreases the forces that the bones have to produce, particularly in the front of your knee, underneath your kneecap, and it's going to potentially see a lot less pressure. Let's talk about medications. Medications. There are a bunch of different medications out there that are supposedly designed to help treat joints. If you look at the Orthopedic Association recommendations for knee arthritis, the first thing that they'll tell you to do is take Tylenol. Tylenol is a pain reliever. That's not an anti-inflammatory. It doesn't cause any damage to the stomach or the kidneys. It can cause long-term damage to the livers if you're taking large amounts over a long period of time. Generally, most people are not allergic to Tylenol, so it's a very good first step. It has very few other side effects. However, once the arthritis gets to a point where that doesn't work, then then we have to move on to something a little stronger. Usually the next step are anti-inflammatories. Medically, these are called NSAIDs, or non-steroidal anti-inflammatory drugs. The most common that you've heard about are aspirin, Advil, Motrin, Aleve, ibuprofen, Bayer. These are all anti-inflammatory medications that are available over the counter. The problems with anti-inflammatory medications, whether they're prescription or over the counter, is there are many side effects. First major side effect is it can cause a lot of heartburn and reflux. Second, people who have a history of bleeding problems, such as bleeding ulcers, or people who are taking Coumadin because they need to thin their blood because of heart arrhythmias, can't take these medications because it overthins the blood. It can cause damage to the kidneys for use long term. It can cause high blood pressure. So we don't want to use these long term all the time, but for temporary joint pain relief, it's not a bad idea, or occasional use. But I wouldn't ask you to take it every day, high strength dose for a year. You're going to develop other problems. The next medication that you can take by mouth, so we just talked about the non-steroidal anti-inflammatories. You can take steroids by mouth. So these are the next step stronger than non-steroidals. Steroids by mouth can cause a lot of problems. It's going to help with any joint aches and pains that you might have, but it's going to cause you to gain weight. It's going to make you feel hungry or thirsty. It can cause emotional extremes. I've had people call me up 2 days after starting, crying, not knowing why they're crying. So you want to be a little bit wary of using steroids. Not only that, steroids can cause bone death. So we don't want that to happen. So I generally don't put people on steroids unless it's one of my last resorts. And we're talking about steroids by mouth. One of the things not mentioned down here, which I would probably even stick in front of medications, is icing. Icing your joints helps. This is an inflammation, or it's an inflammatory problem. Putting ice on the joint that's hurting will help because it actually does decrease the inflammatory response that's produced by your body. Sticking with medications, there's a lot of talk about something called glucosamine. Glucosamine is a supplement that's available at most grocery stores and pharmacies. It's usually given in conjunction with chondroitin. What it is thought to do, it is thought to preserve the cartilage that you have left, to allow that to work as well as it's going to. It has never been shown to increase the amount of cartilage that you have. In the best studies that have been performed, about 50% of people who take glucosamine feel better by taking it. That doesn't mean that everybody's going to feel better. We don't know exactly why and how it works, but we do know that that's what the best studies show. The other part of the good news about glucosamine is that no matter how much you take, there have been no known side effects of the glucosamine. The other stuff that comes in it, the chondroitin, sometimes it has shark fin, sometimes it has a couple of other fish oils, stuff like that. That hasn't been necessarily proven to have no known side effects. But glucosamine in and of itself has had no known side effects. When you take glucosamine, the general recommendation from the Academy of Orthopedic Surgeons is you want to take it 1,500 milligrams a day times 4 weeks. After that, and see how it does. Don't judge it before 4 weeks, but after 4 weeks, if you think you're feeling better, by all means, you're more welcome then to continue using it. Again, there are no side effects except that on your wallet. Glucosamine tablets come as 500 milligrams tablets. They come in 750 milligram tablets. I've also seen 1,500 milligram tablets, but believe me when I tell you those are horse pills, they really are horse pills. So I don't recommend taking those. All right, so let's say you've taken the medications, you've taken the glucosamine, you come back to my office, doc, I'm still hurting, what can I do? The next thing that I would recommend is taking a cortisone injection. Cortisone injection, so this is a steroid that we inject directly into the knee. All the side effects of taking steroids by mouth essentially are gone. The side effect of getting a cortisone injection to the knee, well, first of all, what does the cortisone injection to the knee? It's like taking a huge amount of medication and putting it directly into the knee and only affecting the knee to help bring down the inflammatory response. And that's what a steroid does, is it brings down the inflammatory response. So what are the side effects? Anytime you get an injection anywhere, there's about a 1 in 1,000 risk of infection. A steroid injection, there's about a 1 in 30 risk of what's called a flare reaction, that when you get the injection, your knee hurts for about 4 to 5 days afterwards. There's about a 1 in 200 risk of what's called a flushing response, where the next day your face feels really hot and red and your heartbeat is really fast. Generally that goes away within 24 hours, nor should it dissuade you from getting a cortisone injection, but I just want to warn you about these possible side effects. The vast majority of people who get cortisone injections do feel sore the night of the injection. The next day they feel they did the same as they did the morning before. It takes 2 days for the cortisone to start working, generally about 2 weeks to have a maximum effect. When you get a cortisone injection, and it works, sometimes it works for 6 weeks, sometimes it works for a couple of months, sometimes it works for a couple of years. We don't know. Everybody is independent. It's dependent upon the arthritis. It's dependent upon how much you use your knee and how much inflammation is in your knee. The good news is cortisone can safely be given, at least in my practice, every 3 months for the rest of your life without causing any long-term damage. Some people come in every 3 to 4 months saying, yeah, you know, my knee is starting to hurt again, can I get another cortisone shot? Some people come in every 6 months. Every now and then I have somebody that comes in yearly. I'll be glad to give you another cortisone injection, at least as long as it's been 3 months. When it doesn't last 3 months, then we got to move on to the next step. So in my algorithm of treating the arthritis, we've gone through Tylenol, ice, anti-inflammatory medications, steroids by mouth, which I don't recommend, the glucosamine, now the steroid injections. Now that's not working, you're still having pain. What's the next step? The next step is something called viscosupplementation. The knee has naturally acting lubrication fluid called hyaluronic acid. Hyaluronic acid in people who have arthritis doesn't work that well. That hyaluronic acid that's generated is usually deteriorated pretty quickly and doesn't act as a good shock absorber. So what we do is, usually with a series of 3 injections, occasionally we do it all with 1 injection, but usually with a series of 3 injections, we inject this very thick oil into your knee, and it really acts like a lube job. You come in once a week for 3 weeks, and this oil that we inject into your knee goes to the areas of damaged cartilage and tries to plaster itself to those areas to allow everything to move smoothly. Now, if that works, and it works in about 80% of people with moderate to severe arthritis, if that works, you advise you anywhere between 6 months to maybe up to a year, maybe up to 2 years worth of relief, and you can always do it again. However, the second time being done, it may not work as well. Third time being done, it really doesn't tend to work as well. And then we get to this point where, what do we do now? That's when, if you can't live with the pain, it's affecting your day-to-day activities, affecting your sleep, affecting your ability to walk, affecting your ability to go up and down stairs, and you've tried everything else, you're essentially ready for a total joint replacement. And that's when we start talking about total joint replacement. So what is total joint replacement? Essentially what we do is we take the moving parts of the knee, the thigh bone, the top of the shin bone, and the undersurface of the kneecap. We cut them off, replace them with metal and plastic to allow everything to move smoothly. It's designed to make your knee function like a knee. And we've worked on this for years and years and years. Every year we come up with something better. Right now we think we're doing pretty well. And I just want to talk to you about this specific knee. I've kind of already talked about this, but we'll talk about the risks of knee replacement just after I talk to you about knee replacement. But keep in mind that the goals of total knee replacement are to relieve pain and restore function. In this case, restoring motion. So when you come into the office or just to be evaluated for arthritis, we always get an x-ray. I just want to show you what a normal x-ray looks like. This is the end of your thigh bone, which we call the femur. This is your kneecap. This is the top of the shin bone. One of the things I want to notice, this is generally done with you standing, so you're compressing the bones together. So when you look at this x-ray, you wonder, well, why aren't these bones touching each other? It's because the cartilage in between doesn't show up on x-rays. It's radiolucent, meaning the x-ray shoots right through it without showing up. In a normal knee, that space is normal. The amount of space in between there should be about as much as we're seeing because there's cartilage there that's holding that knee from compressing together. In an arthritic knee, again, the end of your thigh bone, top of your shin bone, and one of the things I want to point out is right here towards the inside of the knee, the bones are touching the bones. So we have bone-on-bone arthritis. Another couple so The other things that happen with arthritis is you start developing bone spicules or osteophytes. Right here you have a little bone spur, right here you have a little bone spur, and right here you have a little bone spur. If you look at compared to these bones which are well rounded, those bone spurs can start getting in the way of motion and inhibiting how much you move. So one of the things we do during a knee replacement is also get rid of the bone spurs. All right. So as we said, what we do is we end up cutting out the end of your thigh bone, top of your shin bone, and replacing everything with metal and plastic. And essentially, we cut out the top of that, top of that, and put a piece of plastic in between them. I'm going to show you a little video. So this is a normal knee. This shows all the muscles around it. This is your kneecap here. In just a second, we're going to take away all the muscles, and we're going to just concentrate on the bones here. Oh, I lied. All right. So during the operation, we make an incision in your skin. Now we're going to cut the top of the end of your thigh bone, top of your shin bone. We cement this into place. We cement that into place, and we put a piece of plastic in, and we put you back together, sew you back up, and call it a day. It takes like 1 minute. So in all seriousness, the operation takes about anywhere between 60 minutes to about an hour and 20 minutes, depending on who's doing it, how fast they're working, what other complications there are. But what we end up doing is really what this video shows. Obviously, this is a glorified simplicity. We make an incision over the front of the knee. Depending on the surgeon, the incision varies in length. Generally, I tell my patients the incision goes from my thumb to my pinky, right over the front of the knee. We go in, we move the muscles out of the way. We don't cut the muscles, we move them out of the way. And we're essentially looking at the bones. Once we look at the bones, we really do, I'm just going to take this apart here. We really do this. And we first take a look at the end of the thigh bone, and we use jigs. We take very exact measurements during the operation. We cut the end of the thigh bone here. We cut the top angle here, bottom angle here, top here, bottom there. And we've now made it conform to a metal prosthesis that we've now sized and made specific to your size and put it right there. Next thing we do is we cut the top of your shin bone. Once we cut the top of your shin bone, we put a metal prosthesis, which we call the tibial prosthesis, right on top. Then once you have these two surfaces that are getting ready to be resurfaced, we put a piece of plastic in between to allow everything to move smoothly. We put everything kind of back together. We check it. During the operation, we always check to make sure your knee comes completely straight. It bends all the way up. It doesn't rock side to side, and it feels stable to us. We do the same thing with the kneecap. I don't have the model of the kneecap with me today, but if you imagine the kneecap sitting right here, we cut the undersurface of the kneecap. We put a plastic button right on top that sits right in this groove, right here, so everything moves nice and smoothly. Before we leave the operating room, we end up cementing these pieces into place. We don't cement into place until we're absolutely happy with how it's going to come out. We cement everything into place. We close everything back up. You're going to be in the recovery room for about an hour. Usually after an hour, you go up to the hospital floor and they start working with physical therapy right away. Now's a good time for me to talk about what that hospital stay involves. Generally, most people are in the hospital for somewhere between 3 to 5 days. We like to get people home as soon as possible because we think people do better at home in the comfort of their own house. We have therapists and nurses coming to your house. They're working on getting your knee moving, meaning one of the things that I work on very diligently in the operating room for the 90 minutes that I'm in there is making sure your knee gets straight and bends all the way. After the operation, you need to work on that as well. I don't leave the operating room until the knee is perfect, but I only have to work for 90 minutes. Once after the operation you're there, it's going to take a couple of weeks for you to get all of your motion back, but you have to work very hard. And they have therapists pushing you to do that. Generally, most people at around 3 to 4 weeks are able to drive, are generally walking into my office with a cane. They're fairly happy. They're still not completely there yet, but they're fairly happy. They're ready to go to outpatient physical therapy. Generally, 3 months after the operation, about 70% of people who have had knee replacements across the country are happy that they had it done. So 70% is not a good number. At 6 months after the operation, about 93 to 97% of people are very happy that they had it done. So I tell people beforehand it takes 3 to 6 months to fully recover. And it really means that the swelling comes down, you get your strength back, you're doing what you want, you're doing everything that you want to do. But the number one thing is, I ask all my patients, are you happy that you had it done? 6 months afterwards, 93 to 97% of people would say they would gladly do it again if they knew they would be as good as they are now. And that's the most important thing. Yes?
You mentioned Baker's cyst.
Yeah.
What is the reason for Baker's cyst?
Okay.
And could you have, without taking care of the Baker's cyst, could you have a knee replacement?
Sure. So Baker's cyst, all it is an accumulation of fluid that's coming from the back of the, that's existing in the back of the knee, that's come from inside the knee joint. Whenever a knee makes fluid, it can show up in the front of the knee, it can get absorbed by the body, or it can show up in the back of the knee. When it shows up in the front of the knee, it shows up as a big swollen knee. When it goes into the back of the knee, it forms this Baker's cyst, which is just a collection of fluid. The first thing, anybody who comes to my office with a Baker's cyst, first thing I ask is, well, why do you have a Baker's cyst? Do you have arthritis? Do you have a tear in the meniscus? Do you have something else that's causing your knee to make fluid? And if we can't isolate, first, we need to isolate the cause. Knees don't make fluid for no reason. So once we isolate the cause, we treat that. If it's arthritis, we treat the arthritis. Every now and then, if the Baker's cyst is in and of itself symptomatic because it's affecting how much you bend your knee, we'll stick a needle in the back of the knee to try to drain the Baker's cyst. Usually that's not successful, but we try. Every now and then it does work. But if we treat the underlying cause, generally the Baker's cyst does go away. So let's say the underlying cause is arthritis, and you've had all the treatment, whether you've had the cortisone, the visco supplementation, the anti-inflammatories, and you still continue to have the Baker's cyst, and it's really just stopping you from doing anything, then the next step is to have a knee replacement. And eventually the Baker's cyst will resorb. Usually it takes about a year to a year and a half.
The second part of that question.
Yeah.
If you don't treat the Baker's cyst prior to the knee replacement, can you still go ahead and do a knee replacement?
Oh, yeah.
Okay.
Yeah. So the biggest problem, Baker's cyst generally doesn't cause problems. Most people find out a Baker's cyst because either they've had an MRI or an ultrasound because they're complaining of calf pain, and their primary care fell back there and you have a bump back there, or you have a Baker's cyst, and that's why they have a Baker's cyst. Very rarely do people come in saying, I have a Baker's cyst that hurts. When a Baker's cyst hurts, Baker's cyst in itself, just sitting there doesn't cause problems, but when it hurts, it's because it's leaked some small amount of fluid into the back of the leg, and that fluid is very noxious to the muscles around it, and it can cause a lot of swelling and pain. Usually when people have Baker's cysts, and we know about them beforehand, they'll call our office and say, you know, I woke up yesterday morning and it felt like somebody punched the hell out of my calf. That's because the Baker's cyst has leaked or ruptured, and it just causes all that swelling and pain. It usually goes away in 3 or 4 days. Baker's cyst will come back usually, but again, the source problem is not the Baker's cyst. The source problem is because the knee is making fluid. Yes?
You mentioned arthritis and Lyme disease.
Yeah.
What has been your experience with that?
So Lyme arthritis is actually fairly rare now because it usually takes over a year of Lyme disease, if not longer, to occur. And especially in the New England area, we're very good about determining when people have Lyme disease, because when it first starts, the knee comes in and it's very, very swollen. Nothing is more swollen than somebody who has an active Lyme arthritis, meaning inflammation in the knee caused by Lyme disease. What we do is we take out that fluid, we send it to the lab, and within a week we have our answer whether it's Lyme disease or not. And it's a very sensitive test. Usually if you have that test done, 99.8% of the time, if you are going to have Lyme disease, it's positive. So it's very hard. You only miss it 2 in 1,000 people. Once you've been diagnosed, you start on antibiotics, and generally that stops the prevention or prevents arthritis occurring because of Lyme disease. You still may develop arthritis, but because of Lyme disease, it's rare.
You were very good. Thank you very much.
Oh, thank you.
Really were enjoying it.
Hope you got something out of it.
Oh, yes. Yes.
Very, very interesting.
Hi, this is Pete Peterson. You are watching Medfield.tv.
Access to our community.